Good evening, ladies and gentlemen. Thank you for joining us today for the ASGBI Centenary Free Papers session. I'm joined today by my colleague Raj Prasidam. My name is Chris Lewis. I'm the Director of Education and Training for ASGBI. So this evening, we will be looking at some of the short paper abstracts and poster abstracts that should have been presented at our ASGBI conference, but unfortunately with one thing and another, things have been somewhat put the mockers on. So, but all the hard work has obviously been taken forward, and we'd like to give the people today the opportunity to present their work and over a short period of time, over the next hour and a half or so. So the format for today will be a short presentation on each abstract to begin with for the first 7 papers, followed by time for 1 question on each paper. If you could put your questions through on the Q&A section for the Zoom meeting webinar, and we'll do our best to pick the most relevant ones best as we can. For the talking posters abstracts, for those people, if you wouldn't mind putting it through the Q&A questions, and we will address them in a discussion section right at the end after everybody's presented. So if everybody's okay with that, we will move on and go straight ahead with our first presentation, which is Libor Hunt on the hidden curriculum unearthing the truth. Thank you very much.
So hello, my name's Libor Hurt and I work as a junior clinical research fellow in Morriston Hospital in Wales. I work as an F3, or to put it another way, I graduated from medical school 3 years ago, and today I'll be talking to you about the hidden curriculum and some of the ways that we found that it's impacting us. Next slide, please. But first of all, let's talk about what it is. Well, the hidden curriculum are the lessons that we learn unintentionally. It includes things like behaviors and attitudes, and also expectations that may be present but not spoken about. And it comes from the cultural and social bias that is, and it's taught by example. This means that the teaching can be both positive and also negative, and it can impact burnout and sleep deprivation. So what we wanted to do is we wanted to determine what the recognition of the hidden curriculum was in postgraduate students. Next slide, please. So the way we did that is we sent out a 9-question survey to postgraduate students. So these are medical graduates in Wales, and the participants answered Likert scale questions, and they range from foundation trainees, so graduates that just left medical school, to quite senior registrars. And we carried out non-parametric analysis on this. So overall, we had 104 responses, where slightly more females answered than males. And the median score for awareness was actually in the middle at 5, where the perceived importance was slightly higher at 8. Interestingly, more people reported positive behaviors than negative. And in surgical trainees, there was very high score for both burnout and sleep deprivation. Females reported more gender-specific hidden curricular effects than males. So that's 5.75 versus 3. And medical trainees reported stronger score for hidden curriculum effects compared to general surgery and orthopedic trainees. And finally, core trainees seem to report more effects, again, when comparing to the other levels. Next slide, please. So overall, the hidden curriculum awareness was variable. Reassuringly, there was more positive behavior reported compared to negative, though the negatives were noticed universally. And it would seem that female trainees and core trainees are more vulnerable, and I think this would warrant more further research. And finally, medical trainees also report more negative elements when compared to general surgery and orthopedic trainees. Thank you.
Thank you very much. That's a very interesting topic that you looked at today, and some quite interesting things that you've come up with. If I can't see anybody else come up with any questions at the moment, but I do have a question on that. I'm interested in your questionnaire. How did you choose the questions to ask, and did you validate your questionnaire in any way?
So the way we took some basic research papers, and we wanted to analyze, well, first of all, what specialty within medicine reported hidden curricular effects. So that's why we decided to go for different specialities. And then we also wanted to differentiate between genders and different levels. And that's why we designed the questions that way.
Did you validate it in any way or do a trial for your questionnaires?
No, the questionnaire was we didn't validate it officially. We just used background research papers. So there's a great paper by Chris Brown and Richard Egan that we used as a basis for this.
Just got one quick question from one of our observers today. How about the Mashlak burnout index? Could that improve your questionnaire, do you think?
Yeah, I think definitely there is scope for further research. I think this was an initial questionnaire to see what the answers would be, but I think that's a very valid point, and that's something that we could look into.
Brilliant. Well, thank you very much for your time and effort, and you certainly put a lot of hard work into it. I'll hand over now to Raj for our next talk.
Thanks, Chris. Could I invite Carla Hope to give the next lecture? It's personal characteristics associated with progression in general surgical specialty training, longitudinal cohort study. Go ahead.
Thank you. So my name's Carla and I'm a surgical registrar in the East Midlands and the current ASGBI Research Fellow. Next slide, please. So the background to this study is we know that the surgical workforce is increasingly diverse. We have more female trainees than ever before, and we also have an increasing number of non-UK graduates entering surgical training. But what we don't know is how the impact of personal characteristics affects progression throughout training. So the aim of this study was to identify the demographic factors, including protected characteristics, which predict a non-standard ARCP outcome during general surgical training. Next slide, please. And we used UK Med as our data source. So this is a kind of a cradle to grave type database that includes information from pre-medical school all the way through to postgraduate medical training. And we included ST3 to ST8 between 2010 and 2017. And our outcome measure was ARCP outcome on a scale of 1 to 4, where 1 was satisfactory, 2 is insufficient evidence, 3 is targeted training required but no extended time to training, 4 is extended training time or released from the programme. And those 2 outcomes were combined because of the very small number of trainees that are actually released from the programme nationally. And we performed a multi-level ordinal logistic regression. And the diagram there just shows the hierarchical nature of our data set. So we had multiple ARCPs nested within trainees, and then we have multiple trainees clustered within different LETBs or training regions. Next slide, please. So our final sample size was 2,730 trainees with over 10,000 ARCP outcomes. And if we start with the left-sided column, these factors are protective. So you're less likely to get a non-standard outcome. If you're a female trainee, you're 11% less likely to get a non-standard outcome than male trainees. And less than full-time trainees were 15% less likely to get a non-standard outcome. And if we move to the right-hand column now, these are risk factors for non-standard outcome. And older age, so for each year increase in age at time of ARCP, you're 13% more likely to get a non-standard outcome. And we also looked at social deprivation. And what we found is that as social deprivation increases, there's a trend towards an increased risk of a non-standard outcome. But we should say that there is some missing data associated with the social deprivation variable. But in conclusion, female sex and less than full-time training were protective factors for standard ARCP outcome. And older age ARCP, an index of multiple deprivation, was significantly associated with non-standard ARCP outcomes. Thank you.
Thank you, Carla. It's an excellent study, and your conclusions, your results are fascinating, really. Can I just clarify, your ARCP outcome 1, 2, 3, 4, is this something you have come up with, or is this from the Gold Guide?
So it's based on the ARCP outcomes from the Gold Guide, but the ordinal scale was developed in a couple of other papers that use the same data set in medical specialties.
The reason I'm saying this is I think you'll find that your 2 is actually 5. Outcome 2 is actually 5, outcome 5.
Oh yeah, so we converted the numbered outcomes onto the ordinal scale. So we changed the number of each outcome.
Okay, thank you. I don't think we have got any other questions. Chris, do you have any questions?
No, nothing. That was very, very clear, nicely written, and obviously somebody has put another lot of hard work into that. So well done. Thank you very much.
Thank you.
So let's move on to the next one now. Chris.
So for our third presentation today, we have Thomas Allman looking at impact, the operative department, human factors training for the whole surgical team.
Good evening. Thank you very much for the introduction. My name is Thomas Allman. I'm an anaesthetic trainee at Royal Shrewsbury Hospital, and I'll be talking to you about the impact training, which is a human factors training that we carried out at Royal Shrewsbury and Telford hospitals. Next slide, please. So the objective of this training day was to maximise the impact factor of MDT human factors training and to utilise simulation within the theatre environment to expose some unknown unknowns and to improve the theatre safety and communication. The way we did this firstly was a simulation within a theatre setting. We had an MDT group of participants ranging from consultant surgeons and anaesthetists, trainees through to nursing staff, ODPs and porters. We put them in tried to be as realistic as possible environment in an elective surgical case that then turned into an emergency. We had actors causing interruptions and we then had a debrief at the end, allowing participants comments and then some on-the-spot training at the time as well. Alongside that, we had 2 group discussions led by consultant surgeons, Mr. McLeod and Mr. Lacey-Colson, and these were around raising concerns within theatre and the barriers that may be there to stop raising concerns. At the end of the day, we asked participants to complete a feedback questionnaire with a scoring system and also some free handwritten feedback comments. Next slide, please. So some of the observations and themes that we came across was we definitely found that the simulation highlighted the lack of knowledge of location of emergency equipment. For example, a chest drain or an inline nebulizer or some certain medications. We found the team didn't know the location of those, and then we could highlight where they were, or we could change the location of these. And I think in one case, we definitely changed the location of something we found to be quite unsafe, and then distributed that information throughout the department. Another theme was obviously to do with communication and its barriers. We discussed that throughout the whole team, and then it was very interesting seeing a consultant surgeon and an anaesthetist having a frank discussion about their communication and the barriers they may have to have effective communication. We also looked at handling interruptions in the theatre setting. We talked about how to minimise interruptions, and then actually when there were interruptions, how to handle them and triage them as well. So looking at the results from the feedback questionnaire, there was results from the theatre simulation. We found that 80% scored it a 5 out of 5, 5 being the most useful, and 20% scored it 4 out of 5. We also gave them a chance to comment, and that was probably gave us a bit more insightful than just the data. And we had some comments about the good skill mix within the group, the benefit of some of the teaching about closed loop communications, and also a comment about how actually it was quite terrifying, and that was really good feedback for us. We probably didn't appreciate that as medical students and trainees, we are very comfortable in a simulation environment, but for a lot of the other professionals, it was the first time they encountered this environment, and it was definitely something we took on board for the future sessions. Results for the group sessions showed that 76% of people scored it a 4 or 5 out of 5, and that 23% of people scored it a 2 or 3 out of 5. Some very good comments about it being informative and thought-provoking. Someone saying that it would make them more comfortable in theatre with the surgeons in the future. And again, we had some very good negative feedback as well. One person saying how actually the discussion was mainly from the doctors in the group, and that we need to empower the other team members to talk up in those discussions. And actually that was very, very good, because that is what that whole session was around, and trying to promote that. Next slide, please. So some of the conclusions: this impact training we thought was an efficient method of delivering MDT human factors training. It was resourceful and impactful. It improved the staff communication and the confidence to raise concerns. On the whole, it was well received, but we also found there was a scope for improvement of the delivery of the training day, and also scope for delivering this in other departments throughout the trust. Thank you very much.
Brilliant, thank you very much. A bit short of time, we've got time for one question. I know something came up earlier on. You mentioned that you changed some of the clinical practice as to where you were storing things. Have you noticed that there's been any feedback with regards to the number of clinical incidents or serious incidents that have been reported? In other words, has these gone down with your implementation of this?
We didn't measure that directly.
You could retrospectively look at that though now, couldn't you?
Absolutely, we could absolutely look at that. I think there were very small numbers, I think, regarding some of the emergency equipment is very rarely used, but that was the whole point of this. So I think looking at clinical incidents, it'd be quite low numbers, but that'd be definitely something good to look at throughout a kind of longer term period.
That's great. Well, again, a lot of hard work, some very interesting aspects looked at there. So thank you very much for presenting today.
Thank you.
Raj, take it away.
Okay, could I invite Jessica Roberts to give a presentation on a multidisciplinary patient safety checklist to improve medicines reconciliation in a tertiary plastic surgery unit.
Thank you very much. So my name is Jessica Roberts, and I'm a plastic surgery trainee in Glasgow in the Cannesburn Plastic Surgery Unit. I would like to share with you this evening the work I undertook on a multidisciplinary patient safety checklist, and how a multidisciplinary team approach can improve medicines reconciliation for the safety of surgical patients. So correctly prescribed medicines are imperative for patient safety. It's important to optimize patients, ensure they're on the correct medications at the correct doses, receiving them at the correct times in the perioperative period. The Scottish Patient Safety Programme therefore set a gold standard that across Scottish trusts, patients should have their medicines reconciled within a 24-hour period via 2 different sources to ensure safety amongst those patients perioperatively. So we took a 30-patient sample across a 5-year period, looking at different interventions used across our team, across time, to try and improve medicines reconciliation amongst our wards. Next slide, please. So the first baseline cycle was performed in 2015 and looked at the baseline of how we were performing on our wards, and the answer was not very well. We only completed a medicines reconciliation in less than half the patients. Although 92% were completed within 24 hours, it was more a box-ticking exercise, as they were only accurate half the time, which doesn't bode well for the safety of patients operatively. As a result, we created a sticker, as seen in the centre of the slide, to put in the patient's medical record to tick whether they'd had their medicines reconciled, their venous thromboembolism checked, and whether antibiotics were required. As a result, in cycle 2 in 2019, we saw increased compliance to 100% because the sticker was always stuck in the notes by the nurses and it was easy to tick the box. But only 64% were complete within 24 hours, and again, only 80% were complete. Next slide, please. So as a result, we as an MDT came together to collectively create the ward round performer you can see on the left of the slide. This incorporates the daily ward round, including a management plan, and is signed and dated as you would the medical entry. However, it includes a 7-point patient safety checklist, which includes medicines reconciliation amongst other patient safety initiatives to ensure that things are checked on a daily basis. This resulted in medicines reconciliation being complete in 90%, 77% within 24 hours, and the accuracy increased to 87%, which is the best we've achieved across our wards. A full survey went out to all members of the MDT and was completed by 38 members of staff, stating the performer was easy to use, improved the structure of the ward round, and that 52% of staff were more likely to check medicines reconciliation. Next slide, please. So in conclusion, a multidisciplinary team approach to audit can implement successful measures that improve patient safety over time, and a focused checklist can increase accuracy and the punctuality of medicines reconciliation for the safety of surgical patients. Thank you very much for listening.
Thank you, Jessica. Very nice study indeed. I suppose we're talking about paper-based notes here, and it might be a bit more easier if you had electronic medical records. Would you agree?
Yeah, absolutely. I think medical records are becoming electronic across the country, but certainly in Scotland, there is a lot that are behind the times, so to speak, in terms of the ward round entries. We are moving to more online records, but certainly across our trusts in Scotland, we are on paper documentation, and it's easy for things to get lost, hence the impetus to check things daily and make it the ownership of the entire multidisciplinary team in the ward round setting to check it's been done daily.
Does it take extra time?
No, so interestingly, I was going to include that, but I didn't have time. So there we did check, and it didn't increase the length of the ward round. And actually in the survey that we sent to all staff, only 17% of all staff felt that it had remotely increased the ward round duration. So both subjectively and objectively, it didn't increase the length of time. In fact, it empowered people to deal with things more efficiently. So there was less hanging about.
Thank you very much. That's an excellent study. Can I pass back to Chris, please?
Absolutely, thank you very much. For our next speaker, I would like to introduce Sheikh Sanjeed Seraj. We're introducing a near-peer surgical teaching program for foundation doctors.
Thank you.
Thank you.
Hi there, hi everyone. I'm Sanjeed, one of the junior doctors working in Basildon Hospital. So essentially I'm talking to you guys today with regards to an introduction of a new adaptive surgical teaching program, which was led by the juniors here in Basildon Hospital since December 2018. Next slide, please. So we noticed that lack of surgical teaching offered to juniors during the core FY teaching. And so in this study, we hypothesized that the juniors involved would have an increase in confidence in clinical performance, and also further develop their communication skills. We also hypothesized that the program itself would continue sustainably long term as well. Next slide, please. So essentially we designed and delivered a 12-week rolling teaching program, which used a 3-tier leadership system involving the consultant, registrars and junior doctors. And so what you see is some gaps on the diagram on the right hand side, and essentially illustrates handovers. Next slide, please. So in terms of the results, we received feedback after each teaching session, after each rotation. The feedback was designed on Google Docs and was collated on Google Drive. And so 107 responses were collated over a 16-month period. Global feedback of the program itself was excellent, with a 8.83 out of 10. And so the respondents indicated that topics were actually relevant, that they found that it was essentially useful and very helpful in their day-to-day practice. So out of all of the 107 respondents, 30 of them actually taught at the sessions. So 27 of them agreed that the program itself improved their skills as a clinical educator. Additional comments, just to add, essentially showed that participants were really gratefully appreciative of teaching leads for their efforts. And essentially they were grateful that this essentially boosted their teaching hours as well for their portfolios, a prerequisite for passing ARCP. So yeah, so essentially all of this essentially indicates that that our small tutorial style with a registrar present to supervise it was essentially effective in maintaining interest and improve confidence in clinical knowledge in the juniors. So with COVID, essentially we had to then try and move this onto an online platform. So you can see on the right hand side, the Lunch and Learn series, where we then expanded our target audience from the junior doctors to say FY1s and to interim FY1s medical students. So yeah, no, that's pretty much it. Essentially, our results just show that our long-term near-peer teaching program was effective, cost-efficient, and sustainable medical education strategy, which is very well received by cohorts of junior doctors. Yeah, and with structured handovers as well. Thank you very much. Thanks for your time.
Very good. Thank you very much. That was very interesting. Certainly something that I know we implement where we work, but it's nice to have some feedback as to actually how the trainees think it actually works. I've just got a very brief question.
Please.
I just had a little bit of difficulty from the abstract working out what your response rate was for feedback. Did everybody feedback, or what was the percentage of people feeding back?
So it wasn't everybody responding back. So we had around about an 87% response rate. So yeah, that was essentially it. Yeah, it was.
Again, 87% is actually really good for a questionnaire. As I'm sure everybody's aware, trying to get people to respond to things can be rather difficult. So well done. I think that was really good. And Raj, do you have any questions on that?
No, it's fine. Thank you.
Brilliant. Well, thank you very much. And I'd like to pass over to Raj again for the next talk. Right.
Let me invite Joshua Clements to talk about bullying and undermining behaviours in surgery, a study of UK and Republic of Ireland surgical training experiences. Go ahead, Joshua.
Great, so thanks for the opportunity to present. So I am presenting today on behalf of both ASIT, the JCST and BOTA, looking specifically at bullying and undermining behaviours in surgery. As a bit of background, bullying, undermining, it's widely documented in the international literature, in the surgical workplace and further through both, pan specialty, pan grade. Move to the next slide, please. So from a methodology point of view, an electronic survey that was piloted within a core study group of ASIT, JCST and BOTA was sent out to all ISCP registered UK trainees in the month of July 2017. As I say, it was validated within this study group, and then an additional consensus session was performed in Edinburgh 2018. Next slide. So from a results point of view, 1,412 trainees responded, which was a response rate of around 27%. There was a number of aspects to the questionnaire. The first one was in witnessing or experiencing bullying or undermining behaviour. 60% of trainees reported having experienced that, of which around a quarter had witnessed that activity weekly. 42% of trainees, and the most commonly reported aspect was relating to sexism, of which female trainees were reporting that more so than women. That was 66 compared to 27% of those respondents, and over half had witnessed this type of behaviour at least once a month. Relating to racism and homophobia, there were 21% of female trainees, around about 300, and 13% of male trainees had reported witnessing or experiencing racist or homophobic language. And finally, 48% of all respondents reported that surgery as a whole had a moderate, high or very high degree of bullying or undermining behaviour. Next slide. In summary, this study demonstrates a much higher prevalence of bullying and undermining behaviour across all specialties in the UK than probably have been previously documented. We recognise, and one of the questions was that this type of behaviour is propagated by all members of the multidisciplinary team. Within this study specifically, it was noted that the experience of this type of behaviour was experienced mostly from consultants in theatre or ward environments. There have been certainly moves since this study has been formed in relation to national campaigns, for example, through the Royal College of Edinburgh, and BOTA have led a number of very successful educational and raising awareness national campaigns into this type of study. And really overall, our feeling has been in recommendations to all major stakeholders that that really we should be moving towards eradicating this type of behaviour.
Okay, thank you very much. I need to hurry along a little bit. Couple of questions really. I know this is a very, very important subject that we really pay attention with and look into in great detail. And you're right, there should be a zero tolerance. Somebody's asked the question, this was actually done in 2017, 2018. Why has it taken 2 years to present?
It's been a formulation of all the data, obviously cross specialties between ASSET, BOTA and the JCST, a combination of a large study group. Agreed, it has been a bit of time since then, but that's really in addition to all the numerous projects that have been done by these groups.
So finally, I've just got one last question, which I think is quite important. Do you think this survey might over-report this? Because there's got to be some report bias with regards to this, because people tend to report things if they've got something to say and don't actually reply if they've got nothing to say. So what's your thoughts about there being a reporting bias in this?
Yeah, well, I suppose recognise somewhat actually sort of say in regards to the lower response rate when you look at sort of 27%. But I suppose, yeah, I'm certainly open to the criticism that the sort of this could be positively biased by those. Our anticipation is that those people that will have had an experience like this will be positively biased through naturally our independent representation in ASSET and BOTA, and with support of the JCST, that as a sensitive subject and as an important subject, that this would have been an opportunity to engage and give an honest opinion.
Yeah, I think you're absolutely right. And even if it is 27% reported and 50% of those show bullying and undermining behaviour, that's still way too much, and we should have a zero tolerance for that. So thanks very much for the presentation. Very, very interesting, and certainly very timely and an important subject to be talking about at the moment. But must move on, I'm afraid. So I'll pass back over to Raj very briefly. Thank you.
Right. Our next presentation is on mentorship as a means to improve integration of foundation year ones in a general surgical department by Dr. Caroline Bradley. Dr. Bradley.
Thank you very much. My name is Caroline Bradley. I'm currently a clinical fellow working at Glasgow Royal Infirmary. I'm presenting this quality improvement project, which I've undertaken in my fellowship year. I'll give you a little bit of background. This has sort of grown from a conversation at a teaching course about the concept of community of practice, which is defined as a group of people who share a concern or passion for something they do and learn how to do it better as they interact. And how a general surgical department in a hospital can be defined as a community of practice, with patient care, surgical progress and the training of junior staff as a shared passion. Literature has suggested that high turnover of staff can destabilise a community of practice, and training design means that generally foundation doctors rotate quite frequently through departments. And as an aside, literature has also shown the value of mentorship in training and support of junior medical professionals. So essentially, GRI is a large central hospital with a busy surgical unit, some complex patients including the pancreatic unit and a nutritional unit, and they have 28 FY1s which rotate for 4 monthly periods. A lack of cohesion was identified between the FY1 doctors and the middle grade senior staff in the general surgical department. If you wouldn't mind, next slide please. And a mentorship scheme was piloted. The reasoning behind it was from several ideas, observation by junior and middle grade staff, formal feedback in the from the GMC survey, and informal feedback in end of block meetings, as well as my own personal experience having done FY1 in the department, moved into FY2 in the department and returned as a fellow. So essentially we looked to try and improve what we thought was a problem with cohesion. So initially we surveyed the outgoing FY1s to talk about their experiences and identify core areas to attempt to address with the scheme. And going forward from this, we've looked to use the scheme to provide support to the F1s, encourage integration and build links, as well as provide more opportunity for feedback, supervised learning events and involvement with audit or quality improvement projects. It's quite an informal scheme. Essentially we paired the middle grade staff with an FY1 and encouraged them to meet 2 to 3 times during the rotation, but they were also welcome to design it as they would like. And the distinction was made between the mentor and one of an educational supervisor. It was meant to be a supportive role, not someone to necessarily assess them. And at the end, they were surveyed again. Next slide, please. Oh, so that's just an example of the survey we sent out. Okay, next slide. Sorry, thank you. So cycle 1 was the outgoing FY1s who were sort of the initial baseline survey, and cycle 2 was the FY1s who had basically been in the department while the mentorship scheme had been running. So as you can see, there was an increase in the feelings of support in the department, increase in the feelings of integration in the department, and an increase in opportunities for involvement with audit and quality improvement and regular feedback that was given. 62.5% reported that they felt the scheme had achieved its aims. Next slide, please. So, as I mentioned, the introduction of scheme made some improvements. However, it has highlighted other ongoing issues with the FY1s. For example, knowing who to contact about specific patients. The biggest disconnect seems to be that the FY1s are ward-based and the middle grade staff are team-based, and that can cause a lot of confusion if a patient is unwell and ward staff not really knowing which specific member of the team to contact. And from this, we've actually gone forward to create essentially a team bleep that one person holds in the day, so that if there are ever problems with the wards with the patients on the wards, they can just page that bleep, and it is basically a direct escalation, and it just stop the FY1s feeling that they're ringing around to various people. And secondly, we did highlight that they still find it difficult to identify opportunities for completion of SLEs. So that was fed back to senior staff. We also tried to encourage the FY1s to be empowered to speak to senior staff and take opportunities to complete these. The engagement did vary, but it was a voluntary scheme. Mentorship can't really be forced. So, but generally the feedback from those that engaged was that it was very beneficial. It's been limited by various factors, specifically COVID. So unfortunately, people having been redeployed, we've struggled to run it in the last 2 blocks. So going forward, the plan is to restart in August and try and develop further. So thank you very much.
Thank you very much. That's very interesting. Couple of quick points. Firstly, were the mentors trained in any way, officially trained in any way?
So the mentors were all recruited again on a voluntary basis, and we had a mentorship workshop for them with some literature provided basically to go through supporting the FY1s. And we did give some structure and suggestions, but again, we tried to leave it up to the mentees and the mentors to sort of set an agenda, so that really the impetus was on the FY1s to try and get out of it what they wanted. So some required more support than others. Some are interested in surgery and others just want some help with FY1. So it was sort of left up to them. Okay.
Do you think bringing back the firm structure and have some continuity of care for your patients would help?
So the interesting thing is that I did FY1 in this department and we were team-based, and I had a brilliant time, hence why I can't seem to stay away. And in FY2, that when I returned as an SHO or as FY2, they had changed. And that was almost where I saw the difference. So I think there are lots of pros to team-based approach, feeling very, ownership of your patients, feeling like you know your team well, but it was causing problems with monitoring and sharing of the workload. So there are pros to the ward-based approach as well, that the FY1s are probably, their workload is more fair and they're getting away on a bit more on time, and there are pros, I guess.
Okay, thank you very much. That's fascinating. I think we've come to the end of all the short papers. Very, very interesting session. Excellent presentations, excellent topics. Thank you all. We will swiftly move on to the talking poster session. And could I also just remind you that after the talking poster session, there are the e-posters which will not be moderated. Please do go and have a look at them. So if I might start off with the first e-poster. Oh, by the way, we will not have any questions here. We'll take all the questions together at the end. So the first poster is from Hopkins. Hospital compound level surgical training quality performance metrics more than a score. Go ahead.
Good evening, my name is David Robinson and I'm presenting on behalf of my colleague Luke Hopkins our study Hospital Compound Level Surgical Training Quality Performance Metrics More Than a Score. In recent times, surgical education in the sense of training and curriculum development have fallen under intense scrutiny with a driving change towards a competency-based system or approach. Yet data linked to individual hospital training quality is sparse. This study aimed to assess training quality related to individual hospital units by means of training performance analysis. We looked at 52 consecutive general surgical hire trainees across 11 sites within Wales, and this consisted of 353 consecutive 6-month rotations. The data we collected included the hospital status, so whether it was a university hospital or a district general hospital, subspeciality of the rotation being undertaken, operative logbook numbers, WBA completion, communications to learner societies, publications and ARCP outcomes. And a composite score was created for each of these domains by ranking the hospitals according to their median performance. What we found was that operative logbook activity varied by hospital in 3 ways. Firstly, total cases. Secondly, the number of procedures with the primary surgeon as the trainee. And thirdly, total number of index procedures, with the 4th quartile performing significantly more than the 1st quartile when you sorted them by composite score. The operative activity also varied according to subspeciality, with breast and endocrine rotations offering trainees significantly more operative experience than vascular, transplant or HBB. WBA completion also varied by subspeciality, but not by hospital status. Upper GI rotations offering significantly more than vascular rotations with regards to WBAs. Publications varied by hospital units, but not significantly by the hospital status or the subspeciality being undertaken. And the same story was present for ARCP outcomes. This information allowed us to create radar plots for each training unit independently. And the slide shows 2 examples of these, with the overall highest and lowest units highlighted. The blue dotted plot on each of the radar plots indicates the overall median for each metric. So in conclusion, with this information, trainee rotations can be planned based on the needs of the trainee at that time. And there's no such thing as a perfect unit from what we can see. Each unit has their strengths and each unit has their weaknesses. However, the advantage of this is that we can marry those strengths and, well, those strengths up with the trainees as they require at that stage in their training. Thank you.
Over to you, Chris.
Thank you very much. Very interesting. Moving on now to emergency laparoscopic appendectomy as a training case, no longer a case for the juniors, by Arin Sahar.
Hi, thanks for having us. I'm presenting on behalf of Ms. Patel, who's one of our core trainees at Huddersfield. We're talking a little bit about laparoscopic appendectomy. Case for trainees, loads of really good topics and lots of bits in the operation that lend themselves nicely to a PBA. But in recent years, the number of cases that you see being performed by trainees has been falling. And we wanted to try and describe the experience of surgical trainees with laparoscopic appendectomy in our unit. And we want to seeing ways where this can be improved over training time. So all patients had a laparoscopic appendectomy every June for 5 years were identified. And there was a change in the core surgical training literature at our place in 2017 in response to the contact training department. There's a change in the rota whereby they were moved on to blocks of acute and elective time, and within that acute time they were moved from on-call to a dedicated period of time in the emergency theatre. Importantly, during that time they had no on-call duties and were simply there to assist and perform acute surgeries with the consultant and the registrar. Over the study period there are 150 patients, and there are between 24 to 45 appendicectomies every month. In common with our normal mastectomy data, very few required open conversion, and those that were needed a consultant surgeon to be present. Interestingly, 2/3 of the operations were performed by a registrar only just trainee. However, there was a clear change before and after the and prior to the dedicated CPOD time. There were no laparoscopic appendicectomies performed by the core surgical trainees, but after 2017, a significant increase. Between the years, the first year in which the SHOs performed appendicectomies in 2017, and what we found was that with the core trainees associated with the registrars and consultants, more specifically, the consultants, one of the key things we found for our junior surgery trainees was that they were often with a different trainer or with a different consultant anytime. And we feel that this change in the rota might help to address some of the concerns that laparoscopic appendicectomy is becoming a registrar.
I think we've had a bit of problem there with technology, so I think we've unfortunately lost Aaron there. I think we should probably just move straight on now to our next presentation. Raj? Raj, you need to unmute your mic.
Sorry, so this is from Ireland. This is a topic called Towards Meeting GMC Generic Professional Capabilities, GPCs, through Simulated Interprofessional Ward Rounds. Mary Morris.
Hello, hi, good evening everybody. Thanks very much for the opportunity to present. Calling in from a very rainy Dublin. So my name is Marie Morris. I'm a senior lecturer and program lead for the Masters in Surgical Science and Practice degree at the University of Medicine and Health Sciences at RCSI Dublin. Just to put it into context, the Masters in Surgical Science and Practice is a one-year program. It's a competency-based program delivered almost entirely through simulation. And this project is part of the clinical skills module, which myself, Professor Oscar Traynor and Mr. Simon McGowan run. So we knew initially from discussions with the trainees and also from the literature that there's always competing pressures for training and service delivery, and that the actual formal training for leadership of ward rounds was something that was lacking. So we were keen to address this, given that we were delivering a new innovative program, that we would address the clinical skills component in an innovative way. We knew from reviewing the literature that the team at Imperial College in London and at RCSI Edinburgh had previously presented some really good research with regards to the teaching component and the assessment component, but we wanted to take this best evidence and expand it further and add something further to the literature. So what we added was twofold. So the first component was the introduction of a social constructivist approach by having multiple disciplines learn with, from and about each other by setting common learning outcomes such as communication, collaboration, shared decision making, and ultimately always at the core shared responsibility for patient safety. So that was one aspect. All participants had a specific role so that engagement was full. The other thing that we added was the volume of the cases. So every week the students reviewed 5 to 6 new cases, which often in the literature it's 2 or 3 recurring cases. So by the time we came up to March, before the COVID shutdown of the university, the students had reviewed 145 cases. The content for these cases is mapped to the intercollegiate core surgical curriculum, and what we also did is we mapped it to the assessment component of the MRC and framework for the MRCS Part A examination. So in conclusion, we were able to see over time that a lot of the core competencies and domains of professional practice and the higher order skills of prioritization and time management and dealing with complexity and uncertainty could be taught in a safe environment through simulation into professional ward rounds. Thank you very much.
Over to you, Chris.
My turn to unmute myself. So the next presentation is Heather Davis. So this is about surgical handover, a national pilot study. Are we doing it well? Take it away, Heather.
Hi, I hope you can all hear me. My name's Heather. I'm a core trainee in Kent. I'm presenting for you today a national study that we did last year looking at surgical handover across England. We all know handover is really important in terms of patient safety and in terms of minimising patient harm, etc., and transfer of professional responsibility, but there's a growing appreciation of the importance of handover in terms of human factors, situational awareness, teamwork, and as a teaching tool. The Royal College set out a number of key principles that handover should see to uphold and maintain despite variation across the country in terms of complexity and so on, what we're doing. And this handover seeks to address how well we're meeting these and what areas there are of improvement. So we circulated an anonymised online questionnaire after conducting a local feasibility study here across England, and we obtained responses from 30 trusts. The results are pretty good on the whole. So generally we're meeting standards in terms of handover setting, but there are still areas that need some significant improvement. Still, handover is happening in some areas where we're not able to maintain confidentiality, and still handover is happening in some areas where you don't even have access to patient information. We're still being interrupted in handovers, and for those that are interrupted, it's a regular occurrence, perhaps a cultural problem in terms of what handover means. The college are very clear that an introductory briefing is really important for situational awareness, bed flow, the state of the complexity of the patients, and how well we're staffed in terms of both nursing and surgical cover. And across the country, we saw that this isn't being done well, if at all. Only 27% held an introductory briefing, and that we noticed was something that really ought to be upheld. Again, another key weakness that we identified was that very few handovers included the wider multidisciplinary team. Although generally we had very good representation across the surgical rankings from junior to consultant, very few, if any, MDT members were there other than perhaps the nursing staff in 20% of cases. In terms of the content that was presented, generally again done quite well, but there are some areas of improvement. We're generally discussing demographics, but we're not always able to communicate or not communicating the results of significant investigations, and we're not always clear on the working diagnosis. Something that I found quite surprising is that we're not always working with our guidelines or checklists for management of what we see commonly on the general surgical take. One thing that did come up, which would certainly be patient concern, is that it's not necessarily always clear who is responsible for the patient, not simply just in terms of the team, but how to contact them and which doctor on the day is responsible. That's not just important for the doctors working the team, but the nursing staff as well. Another key area of concern that we found is that handover really isn't being used as a teaching tool. Now, the literature is full of papers asking for handover to be used for training in terms of being able to calibrate our decision-making processes, see how we did, did I get the right diagnosis, did I do the right things, etc. And it's not done. So 28% used it as an opportunity to teach, and that's at all levels. And more concerning is that only 26% reported that senior clinicians encouraged questions, which perhaps suggestive of either a misunderstanding of the role in teaching and handover, or perhaps a role of saying actually there's a cultural problem in how we do our teaching. There were free text suggestions looking at things like using electronics, review of imaging, and one thing that did come up time and again was auditing attendance and perhaps improving the MDT involvement that way. So Unfortunately, things have gone on hold because of coronavirus, but going forwards, we wanted to take the 3 areas of looking at introductory briefing, MDT involvement, and predominantly teaching, look at areas of good practice across the country and see if we can take these forwards and develop Handover as a formalised training tool for trainees at all levels. I'm happy to take any questions, and if there's anything you'd like to clarify further, I'm happy to do so.
Okay, thank you very much for that, very clear. We'll take questions at the end. So Raj, next presentation, please.
Okay, could I invite Mr. Rahman to talk about improving the foundation surgical skills and critical assessment and management of junior doctors in the District General Hospital. Mr. Rahman.
Hello, good evening everyone. I'm Dr. Mubarak Rahman. I'm a surgical registrar. And the idea of this study was basically taken from the GMC Training Environment Survey of 2018, which showed that the doctors at the foundation level, a higher proportion of them were had a feeling of being forced to cope with the critical emergencies beyond their scope of confidence and knowledge. We surveyed a total of 14 foundation doctors and were asked about their confidence and knowledge for coping the day-to-day critical surgical emergencies. The objective of this study was to improve basic set of surgical skills of junior doctors and improve their confidence and knowledge in dealing with acute general surgical ward emergencies. We conducted a survey of 14 foundation doctors, and then we made a baseline, got a baseline data, and then we conducted a workshop which was designed in accordance to the pre-workshop survey. It was a one-day course divided into 2 sessions. One session was of surgical skills, giving them an insight of common instrument handling, reef knots, and the basic suturing techniques like simple interrupted suturing and vertical mattress suturing on dummies. The second session was simulation based, and a clinical scenario was simulated, which was led by a consultant, and was a group of participants was involved in it, and the other people watched it through a video recording. The participants were then given positive feedbacks, and their shortcomings were addressed by the consultants involved in the course. And at the end of the course, a survey was taken from the participants regarding the usefulness of the workshop. And another survey was done a month later to see the effectiveness and benefits of the course in their ward and clinical life. All the attendants participated in the survey, and all of them agreed that the training met their learning objectives. All of the participants were of the opinion that such workshops should be frequent during their foundation period, and the 86% of the participants strongly agreed that the course was equally helpful in addressing their professional development and in helping them in choosing their specialties of interest. The conclusion of the course and the data was that simulation-based skill course provides a safer and an effective method of improving the confidence and the knowledge of the foundation doctors for dealing the critical surgical scenarios in the ward. Thank you very much.
Okay, thanks very much. Chris, next one.
Yeah, thank you very much. I'd like to now introduce Lewis Coisia on the multidisciplinary team approach to reducing PJ paralysis and time spent in bed in post-operative patients. And I love that term, PJ paralysis. Take it away.
Thank you very much. Hello, my name is Lewis Coisia. I'm a consultant physician at Imperial College. And,
a little bit muffled there. We can't hear you very well.
Is that any better?
Perfect.
Lovely. So my name's Louis Quasar. I'm one of the consultant physicians that works very closely with our surgical teams at Imperial College and mainly St. Mary's. Today we're going to be talking about our project looking at immobility amongst patients in the post-operative setting, work that I did with some colleagues of mine a couple of months back. What we identified on a daily basis, that when we were seeing patients post-operatively on our general surgical ward, that lots of the patients were spending predominant time in bed and they weren't mobilizing. And as a geriatrician by background, there's a massive push looking at PGA paralysis, which is the notion that we try to get our elderly patients into their normal clothes, sitting out and mobilizing on the ward as soon as possible. And we know that with patients that are less mobile, particularly surgical patients, there are increased risk of venous thromboembolism and complications such as post-operative pneumonias. So our aim in the study was twofold. We firstly wanted to look at how much time patients were spending in bed and not mobilizing. And we also wanted to look at any barriers to prevent them from mobilizing more. And our initial assessment was quite startling. We identified that on a daily basis throughout the day, 65% of our post-operative patients were actually sitting in bed or lying in bed for the majority of the day. We took this information back to our MDT and we had a big room session where we sat down and we brainstormed about issues that were happening on the ward, how we could make the situation better. And at the same time, we got feedback from members of the multidisciplinary team, so therapists, from nurses, from doctors, healthcare assistants, from the catering staff. And we also surveyed our patients and relatives to get some more information. And what we found was that there was a huge amount of lack of education and lack of awareness amongst patients, amongst relatives, about the importance of getting up and being mobile, and also amongst staff members, so the wider healthcare team. Other barriers that affected the ability of patients to get out were related to things like pain, limited staffing levels, so reduced staffing levels on the ward meant that it wasn't always possible, and also lots of our patients being connected to drips, drains, PCAs, etc. made things much more complicated. So as a response, we decided to undergo some interventions, and this included educating the healthcare professionals. We also improved patient education, so we produced the patient leaflets. We put posters up at the end of each patient's bed to identify if they could mobilize and how they should mobilize. We undertook teaching for our members of the multidisciplinary team, and we focused all of this on a 1 week period, which we dubbed the sit-out week, where we basically highlighted amongst the members of the MDT as well as all patients on our ward that the emphasis would be that everyone should sit out, mobilize, and spend less time in beds. The impact was much improvement, and what we're hoping to do is look at this having an impact on patients' length of stay and their outcomes longer term. Thank you.
That's brilliant. Thank you very much. That's very, very interesting. And I've got a question about that a bit later on, but we'll move on quickly to our final post of the evening.
So can I invite Michael Dick to talk about achieving and maintaining excellence in undergraduate surgical education?
Hi, I'm Peter Cordner, and I'll be presenting in Bath and Mr. Dick. University Hospital Monklands is a small district general hospital in the west of Scotland. We have around 100 surgical beds, which covers upper GI, lower GI and urology. Part of the block that University of Glasgow students have to undergo, who are the students who are with us, involves breast and vascular as well. We typically get third and fourth year medical students from the university over approximately 5 weeks. Medical students will complete a survey that goes to university, which they benchmark all of their blocks from the west of Scotland. In 2015, Monklands was red flagged as a significantly underperforming hospital within the west of Scotland. So through a multidisciplinary team approach, looking at the feedback from the students and team members, we identified areas of poor performance and implemented to facilitate these changes. So some of the main interventions we performed was personalised timetables, which had a large initial investment. However, once the templates were built for the students going forward, we could give each student their own timetable. It substantially improved how they felt about the organisation of the block. We mapped our teaching sessions to the university's curriculum. Teaching was only scheduled with doctors who volunteered to teach. There was no enforced teaching. We implemented specialty clinics, including some nurse-led clinics in both stoma nurses and breast nurse clinics as well. Students are all allocated a dedicated mentor who they could be in contact with during their time. And we always ensured that within our organised teaching time, that everyone had enough time. There was sort of leeway within the time of teaching. We also do a comprehensive introduction to theatre course, which has since been adopted by the University of Glasgow. However, it covers the whole region of Lanarkshire, with multiple students coming to the Monkland site to get an introduction to theatre and learn some basic theatre skills and etiquette on our site. We had dedicated clinical skill sessions throughout the whole block, and we teach them their core procedures according to the GMC's outcomes for graduates. With a significant improvement with the student feedback in the 4 years, we're identified as the most improved undergraduate surgical.
Peter, you just muted yourself.
Yep. So we're identified as the best hospital within the west of Scotland for undergraduate surgical teaching. And the University of Glasgow is currently just awarded the best medical school in the United Kingdom as well. We can maintain this throughout the 2 years after intervention, and we're going strong today. Thank you.
Thank you very much, Peter. It's an excellent talk. Look, we come to the end of the talking poster session. Could I invite all the panelists back on view and just mention the fact that the e-posters are online. Please do have a look at them at some point. All the topics I thought were excellent and varied in nature, and the speakers stuck to time. Thank you very much. So should we start off with some questions? I invite all the people attending to put in some questions on the Q&A box. Let me start off with asking David Hopkins, I think. The study which showed that breast and endocrine trainees got more operating than transplant HPV. Is that correct?
Yeah, that's correct.
I presume that's because the breast operations or the endocrine operations are shorter and you're counting the number of operations as opposed to the number of hours spent in theatre.
Yeah, it's based on number of cases. So it is primarily due to the complexity of the varying sort of subspecialties and what the length of operation is.
Okay, thank you. Chris?
Yeah, I've got an interesting question actually, which I'd quite like to pose towards Dr. Koiser. In my experience, what I tend to do is nag my patients to get dressed because the PJ paralysis tends to be related to the PJs. Do you know of any evidence that looks at whether mobilisation is better if patients are getting dressed or if they're actually remaining in their awful NHS gowns or pyjamas? Or what do you think about that as whether that would help with recovery or length of stay?
So from geriatric patients, there is definitely data suggesting if patients are wearing their normal clothes, especially the cognitively impaired ones, they do much better and they're much more likely to mobilize. I think the complexity of overlaying that onto surgical patients is the fact that our patients have things stuck in them. They're, especially from my general surgical patients, they've got drains, catheters. It's much harder to allow people to wear their normal clothes with these additional things on top of that. And at the same time, it's about educating them. You said nag, which I think is probably the right word there, but I think it's lots of our patients have a period of time before the operation where we should tell them, you know, one of the things that you can do to improve your outcome is get up and move. I think more patients and their families nagging them on a daily basis will also have an impact as well.
Sure. I work predominantly with emergency cases, so pre-operatively informing these patients is a little bit more difficult because they usually come in feeling sick as anything, get their operation and then get better. So that's a little bit more difficult for acute patients, but I'm really glad there's some information out there to support me nagging these poor patients. Thank you very much. Any more questions from anyone?
There was a question earlier on the Q&A let me see who it was to.
But unfortunately, I've just been in contact with him and he's lost his signal and connection.
All right.
So he's
it was about the laparoscopic apnea.
It was, and I did try and answer that. I typed an answer to that as best as I could. I think if there's no further questions, we should bring this evening to a close. I think it's been very successful. I've thoroughly enjoyed the talks, and they've definitely been educational and informed me of quite a lot of varied and wide subjects and subject matter. So thank you for all the presenters today. I think you've done a wonderful job, and it's really nice that we've been able to show your work off despite the current climate, shall we say. Just to remind everybody, the next free paper session will be tomorrow evening at a similar time, and an educational webinar from ASGBI will be on Thursday evening, and that will be pre-pyloric perforations, pitfalls and possibilities by some of our upper GI specialist colleagues. So that's something else to look forward to. Again, I'd just like to remind everybody if they can look at the e-posters and get just to recognise some of the a lot of work that's gone into a lot of these. So if you could spend a few moments having a look at those, it'd be greatly appreciated. So thank you very much for attending, and hopefully we'll continue to have such good participation in the talks to come. Thank you, everyone.
Thank you.
Thank you.
Thank you.